Hello dear students, I welcome you all to today's topic, which is on postnatal care. Now this is this kind of case is a very dicey case for postgraduates because very basic elementary questionnaire can be asked from you in a postnatal case. This can also be kept in your ward rounds if at all it's being asked, and the most important is the history, because mostly I've seen postgraduates getting confused in how to present the case history in a postnatal case, which is a very big reason for their not making in the DNB practicals. Just remember that if this postnatal case comes to anybody as a short case or a long case, you cannot fumble, you cannot not know how to write down the history. So today I'm going to give you a brief tutorial as to how to write the history, how to speak the history in what order, and how much to speak, what should be the language, and where to save yourself from the examiner. What kind of questions can be asked from a postnatal case is also going to be covered by the end of this this session, and lots of other questions actually I can ask, but just because of time constraint and to be just fair with all the other topics, if I start covering this topic in such depth, it will be unfair to the other topics. So there is a lot to ask, but I've restricted it to the bare minimum postgraduate level questions which can be asked to you and which you should know, plus you would know how to beat about the other questions if at all they're asked. So let's begin. My patient, Mrs. X, aged 26 years, housewife by profession, belonging to the lower middle class, is wife of Mr. Y, who is driver by occupation and a resident of so-and-so place, is P1L1, today, day 2 of delivery. History of presenting case. Patient has delivered a male baby one day back at 12:50 p.m. with history of forceps delivery due to fetal distress. Weighing, the baby weight is around 3.2 kgs and currently alive and healthy with mother, breastfeeding well. Patient has a Foley's catheter in situ and the early urine output is adequate at around 30 to 40 ml per hour. She is taking soft diet and has passed motion once. Now the antenatal history. This one was a spontaneous conception. It was a booked pregnancy in this hospital in the first trimester. All 3 trimesters were uneventful. Patient gives history of regular antenatal visits except for a gap of around 1.5 months in the 6 months of pregnancy when she went to her village. Patient gives history of regular intake of iron and calcium tablets, and investigations done were so far normal. The pregnancy went on smoothly till the last trimester, and she was also immunized fully. Patient gives history of follow-up report 6 days. Patient gives history of following up 6 days back when she was asked to report in case of any pain, abdomen, decreased fetal movement, leaking or bleeding per vaginum. She was admitted in labor room on so-and-so date, you can always mention the date, with pain abdomen, and she delivered a healthy male baby on the following day at 12:50 p.m. with the help of query forceps. Baby cried immediately after birth. It weighed around 3.2 kilograms and is alive, healthy, on breastfeeds. Baby was vaccinated on day 1. Obstetric history. She's married for 1.5 years. It's a non-consanguineous marriage. Her LMP was so-and-so and her EDD was so-and-so, and she delivered almost 1.5 weeks before the EDD with going into labor spontaneously. Menstrual history. Menarche was at 14 years. Past menstrual cycles were regular, coming at a gap of around 28 to 30 days, lasting for 3 to 4 days. Soaking 2 to 3 pads per day. No history of dysmenorrhea or passage of clots is present. Past history. There is no history of hypertension, diabetes, hypothyroidism, TB or epilepsy. Personal history was normal in appetite, regular bowel and bladder movements, and though she did have disturbed sleeping movements in the past, but there has been no addictions present. So on examination, my patient is conscious, cooperative and oriented to time, place and person. Her height is so much, weight being so much, and her current BMI is 24 kgs per meter square. Vitals, she's afebrile to touch. Pulse is around 88 per minute, regular rate and rhythm, normal volume. Blood pressure in the right arm in sitting position is 126 per 76 millimeters Hg. Respiratory rate is around 16 cycles per minute. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Thyroid, the examination of thyroid appears normal. Breast shows normal changes of pregnancy. There is no evidence of cracked nipples or any tenderness lump in the breast. Colostrum could be expressed and nipples were not retracted. Systemic examination, chest and CVS were found within normal limits. You can also expand it and say, as I've said and enumerated number of times in different case histories. Abdominal examination on inspection, it appears to be normal in size and shape. All the quadrants were seen moving equally with respiration. Hernial orifices were found intact. Linea nigra and stria gravitarum were present. Umbilicus was central in position. On palpation, there is no guarding, tenderness or rigidity. Uterus was well involuted and was around 22 weeks in size. The symphyzofundal height was around 20 to 20 centimeters. No organomegaly was present. On percussion, there was no evidence of any free fluid in abdomen. Auscultation, normal bowel sounds were heard. Local examination, the perineum appears normal. The episiotomy site is seen to be healing well. There is no active bleeding seen. There is no swelling around the episiotomy site. Foley's catheter is seen in situ. Lochia rubra was present. It was non-foul smelling and normal in amount. Neonatal examination, baby is active, feeding well. She feeds around 10 to 12 times per day, roughly around by 2 to 3 hours gap in between she naps. She has passed meconium once and sorry, it's a male baby, so I'm so sorry. It feeds around 10 to 12 times a day, roughly by 2 to 3 hours gap in between he naps. He passed meconium once and was and has wet nappies around 10 per day since delivery. Temperature is around 98.6 degree Fahrenheit. Pulse is 142 beats per minute. Respiratory rate is around 52 per minute, and there is no evidence of any respiratory distress. Anthropometric measurements. The weight of the baby is around 3.2 kgs. Length is 48 centimeters. Head circumference 34 centimeters, and chest circumference is around 32 centimeters. Head to toe examination. Head caput is present. Eyes and ears seen normal. Chest, abdomen, extremities, and external genitalia appear normal. Anal orifice is patent. No evidence of any birth injuries or congenital defects could be seen. Reflexes elicited were Moro's reflex, rooting, sucking, and grasping reflex were present. So, my patient who is a 26-year-old lady, Para-1, living 1, on day 2 puerperium, gave birth to a term male baby by forceps delivery. Mother and baby are currently healthy. Baby is exclusively breastfeeding and is immunized till date.
Okay, doctor. What do you want to check and monitor for the first 2 hours post-delivery?
First 2 hours post-delivery are the most important, time or after the delivery. We are mostly concerned about the bleeding per vagina or any hematoma or anything that is developing around. Neither are we bothered about, usually patient is afebrile. If at all there is any infection, so after post-delivery, the complication that we have to look forward to is PPH and any kind of infection, mostly, or any hematoma which is being formed. So we have to basically check the pulse of the patient, obviously the temperature of the patient, the blood pressure of the patient, and urine output, or any signs and symptoms of distress in any which way. Suppose she's having ongoing bleeding, which is maybe concealed because of vulval hematoma, then she will suddenly feel weak slowly. Her pulse is going to increase, blood pressure is going to fall. So basically the vitals are very, very important to be looked forward in the first 2 hours, and we are basically more concerned about sudden hemorrhage, that is postpartum hemorrhage in any which form, be it vulval hematoma or be it atonic uterine PPH.
Okay, doctor. So what are alert signs in first 2 hours post-delivery?
Yeah, the rise of blood, the rise of pulse and the dropping down of blood pressure, because first sign is actually the rising of the pulse. So we should know the baseline pulse the moment she was delivering, immediately after delivery, because obviously when she is delivering her pulse rate is going to be high, but immediately after the the delivery, when the stitches are also being given, she should, once she's shifted to the room, her baseline pulse should be checked. And if there is any 10 to 20 beats rise of this pulse, that should be at least notified once, and very strict vigilance should be henceforth kept. IV fluids of a very broad IV line should be secured in all patients who have delivered, and crystalloid solution should always be kept ready for any kind of episode that can happen. Obviously, prophylactic oxytocin should be already given, so that if it can just allay any episode of torrential PPH. So the most important danger signs to look forward is sudden increase in pulse, pallor in the patient complaining of weakness, confusion, lassitude, and dry tongue, dehydrated look, confused look, and a drop in blood pressure.
Okay, doctor. And how will you manage an infralevator hematoma?
Infralevator hematoma is still easy to manage because the bleeding is actually localized below the level of levator ani. It's actually bounded by levator ani superiorly, and inferiorly by medially by the the sphenial body, laterally by the fascia lata and the Coles fascia. And this hematoma can easily, once it's seen, of course it causes a lot of pain to the patient, which is out of proportion to the episiotomy stitch line, and a lot of local bulge will be seen. On examination, you'll find a complete bulge on the site of episiotomy that you can easily take this patient up for examination under anesthesia. Just drain out the hematoma. See, if it's a small hematoma, it all depends upon the size. If it's a small hematoma less than 3 centimeters, you can just wait and watch, give cold compress, give hot compress, and then just wait and watch. But if this hematoma is already big, right, 5 to 6 centimeters or more, and the patient is looking exhausted, pale, with signs and symptoms of impending shock, it's always better to examine under GA. And if it's required, you can always drain the hematoma, secure the suture, the site of bleeding, and observe the patient very closely for any further signs of bleed and signs of recuperation. So you have to put a Foley's in situ and watch for very closely the vitals and the urine output in this case. So that's how.